All right. Well, we've got what do we got, like 6, 7 folks on here. Maybe we'll just give everybody another minute or two to join us, and then I'll tell you guys who I am, why I'm here, and then I've got a case that I was gonna share my approach to and how I went through it. But I'm also hoping, just as Dr. Cowgill often does, is that somebody else on the call is going to have something interesting to add from a treatment perspective or cases you're working with, or something else. So it's less of my voice and more of everybody else collaborating on this call. Maybe one more minute, then we'll dive in there. Well, if anybody's got something at the top of your mind right now that you want to get at the top of the list for sharing, please unmute and join in. I don't recognize a lot of names here. I see Cedric's on. A few other familiar names. Yeah. UPenn in the house now. All right. Well, we're a couple minutes in here. Good morning. Dr. Cowgill was unable to make it today to lead the session, so he tapped me to try and fill some pretty hefty shoes from leading this group perspective anyway. I'm certainly not going to pretend that I've got any of the expertise that he does, but I do like to talk a little bit, as some of you guys may have noticed on these calls, these Friday IRRR sessions. So I've absolutely I've got a TPE case that we treated recently here at Cornell, that I was going to share kind of my thought process through and just open up the pull the curtain back and show you how I approach them and some of the tools that I've used, not because I think I've got the right way to do it, but because that's what I found has worked for me, and I've pulled in from a lot of mentors that might be on these calls, but also so I can get a sense of how you guys do things and get some feedback and really try and gain some strength in my approach to these cases through this collaborative effort here. So that's kind of my main agenda for today for the group. But certainly before I dive into that, I'd rather hear from other folks running cases. If there's anybody out there that's got an active case or a recent case that they wanted to talk through, that would be most ideal. So I'll pause for a minute and just open the floor.
We had a really cool multiple myeloma causing hyperviscosity that we did TPE on. So we did that earlier this week. That patient responded really well. We did 3 treatments. It's probably the second or third hyperviscosity patient that I treated, and they've all tended to have pretty immediate improvement in their plasma viscosity. And I mean, you can even tell just by like aspirating their blood and how viscous it is. That dog did really well and went on to get chemo. And so we pulled some samples on that to be able to look at protein electrophoresis before and after those treatments. But we ended up doing 3. That dog did great. The ASFA guidelines suggest that for hyperviscosity, you treat daily or every other day until essentially the hyperviscosity is improved. So we felt pretty good about stopping after the 3rd treatment. He got chemo, and so his total protein went from greater than 12. I don't know what it was on the actual quantification. And then it was down into the, I think 7.0 after the first treatment, and then remained in the 7s thereafter. So pretty significant improvement in his serum proteins. So yeah, that's a pretty fun case.
That's really cool. I've consulted on a couple here in-house and didn't wasn't able to pull the trigger on treating them. And one of the reasons was, so a question for you, JD, is, the patient that we talked to most recently didn't really have any overt clinical signs or any other certainly hyperglobulinemic, and definitely lab work wise suggested that this could be a good application of TPE for it. But they couldn't really put a marker on, hey, this patient is doing poorly secondary to this, so we should get those protein levels down. Did your patient have some clinical signs or something else that really drove the decision to pursue this, or was it a, hey, we know hyperviscosity has negative consequences, let's get ahead of the curve?
Yeah, I think it was the just severe hyperproteinemia and the blood was thick. The dog also was hypertensive and blind, associated with whether it was hypertension or whether it was hyperviscosity causing just the really poor flow through his retinal vessels combined with the hypertension, but definitely had some clinical signs of it that was the reason that the oncologist referred it over to us so that we could manage it. So this actually came from a different hospital who they recognized that this patient was having clinical effects of the hyperviscosity and sent it over. I think hyperviscosity itself we don't really have a good test for it, other than like how thick is the blood, which is obviously super subjective. And sometimes you'll run into the scenario that you can't even run a chemistry panel because the paraproteins that are there interfere with everything. But hyperviscosity is a category 1 indication in people. So it is considered to be standard of care to get TPE. So, I think for this dog, it was a big golden retriever. The risks associated with it were exceptionally low. Benefits were certainly, we thought that they were there. And the dog was clinically much better, like came in and wasn't walking when you guys started. And then after the first treatment was able to hobble back to its run. And then after on this morning of the second treatment, which was only maybe about 12 hours after the first, was able to walk to the dialysis room and get treatment and looked great afterwards, looked like a normal dog other than being blind on day 4 when we did the third treatment.
Very cool. Yeah, the patient that we discussed pursuing this for, also a bigger dog. So again, I think risk versus reward, aside from cost, that was part of the decision making for this pet's owner. Had an occasional episode of epistaxis that was maybe attributable, but didn't have any blindness, was not hypertensive. So again, some of the other markers that make it a little bit more straightforward. I did try and provide some, I guess, some context. If you're that sludgy at the microvascular level, you've certainly got to be experiencing or causing some degree of cellular damage and lack of good oxygen delivery to those tissues, including the kidneys and other vital organs. So I made my best pitch for it and did pull out the ASPA guidelines to try and suggest that it would be a standard of care for a person in that same situation. JD, did you kind of go along the same? It sounded like your time course, day 1 and 2, and then in day 4. Did you also target a 1.5 or so plasma volume exchange for each of those treatments?
Yeah, we did a 1.5 plasma volume exchange, and the ASA guidelines would suggest daily or every other day until symptoms improve. So we kind of just stuck with our same schedule. Day 1, we ended up getting started late in the day just because it was sent over to us and didn't arrive here until the afternoon. So we got a catheter in, treated day 1, and then treated day 2, which would have been not quite, not 24 hours after we finished. It was probably more like 12, 15 hours after we finished, and then skipped a day. And then we did day 4 and pulled the catheter immediately after the treatment.
Interesting. One of and if I'm recalling right, it's been a few weeks since I went through all the human end of it. It did seem to suggest that there could be an indication for repeated treatments down the road, depending on their response or not to the chemotherapy and whether or not that hyperviscosity was suppressed enough after TPE and under chemotherapeutic approach. Is that something that you guys are keeping an eye out for, if there's some rebound or some lack of response to the chemo?
Yeah, we talked to them about doing anywhere from once every 1 to 4 weeks is what's described in people as maintenance therapy. We're hoping we don't need to do it. Owners are aware and they're on board with placing a new catheter if we need to, but we thought hopefully the risks would be low since we were just starting chemo, and then we would rather have this catheter out in this dog that was getting chemo, so we didn't have to have the potential risks of having infection associated with it. So they were on board to pull it, which is what we ended up doing.
Yeah, oh, that makes a lot of sense. It'll be curious to see if well, now you said you've treated a couple of these guys. Have any of the previous ones needed a maintenance treatment down the road?
No. So they've all done pretty well. I had one that was a more like a Waldenstrom's macroglobulinemia secondary to lymphoma, and that dog actually just needed one treatment, and the hyperviscosity was dramatically improved and got chemo, and we didn't have to do it again. And then one other patient that I think we ended up doing 3 treatments, but none have needed the maintenance. I think because we end up getting many of these patients at the time of diagnosis, and at least a lot of them have at least a partial response to the chemo, if not better. So their proteins are not too bad and they generally don't need it. I think in people, they'll see it where they're just having more resistance to chemo. They're still trying different protocols, but they're still looking at the big picture of, okay, we're going to manage this patient over, this patient's not going to be euthanized. This human's not going to be euthanized if they're not going to do well. So we have to keep figuring out how to get their hyperviscosity under control. So yeah, I've never had to do the maintenance, but we did bring it up to the owners and they're on board to do it if we do find ourselves in that situation.
Nice, terrific. One other question that came to mind. Oh yeah, timing wise of initiating the chemotherapy. Can you take us through it sounds like you initiated the chemo after the course of TPE. Can you take us through the decision making around that?
Sure. So the oncologist wanted to start cyclophosphamide. So cyclophosphamide only has about 30% protein binding. So we probably weren't going to remove that much with TPE, but we did decide to wait until after the second treatment before we did chemo. And it has even though the nadir, you normally see it at about a week, that's in terms of the leukopenia, that's all the pharmacodynamic effect. The plasma half-life of cyclophosphamide is pretty short. It's only about an hour or so. So we treated after treatment 2, realizing that after treatment 2, by the time we got to treatment 4, there'd be minimal drug that'd be left behind. So we weren't worried that we were going to be removing a significant amount with the 4th treatment. Could we have given cyclophosphamide and then done TPE right afterwards? We could have. It probably would have removed a very small amount that might not be clinically significant, but we just decided, at this point, the dog hadn't received it. Why worry about removing a fraction that we really can't quantify? Let's just give it after the treatment number 2.
That makes sense. Oh, interesting. Does anybody else have the opportunity to treat one of these hyperviscosity syndrome dogs?
We had one case at North Star that we almost treated. That's Fabrice. Unfortunately, the dog had already multiple chemo treatment. That was the dog from one of our intern. The dog was present with neurologic signs. Acutely became, non-ambulatory and had neuroscience. So that's why, we're talking about doing the treatment. And Onco was mildly optimistic about response to the treatment because they still had like some options for like chemotherapy, but unfortunately, the owners decided to stop. But we were like close to start the treatment, but I was based on the neurologic signs. But that would have been a good case. That was a big dog, so it was pretty safe for the TPE treatment.
Yeah, these types of cases, don't get me wrong. If we get to my IMHA case I was going to present, those are some of my favorites because they do. I've had good success or luck with them, whatever combination there is of that. But it's these novel is maybe not the right word, but expanding the repertoire of the types of cases we're treating with some of these extracorporeal modalities, and really expanding our footprints, and advancing treatment for these patients is really exciting to me. So I love hearing about these cases. That's really cool. And even if it's close, Fabrice, at least the conversation is happening. Similar, I was thrilled when our oncology folks actually approached me about it, as well, rather than I'm usually the one running around the hospital trying to dig up new and interesting ways to help educate my colleagues on what the options might be, to involve some of our extracorporeal modalities. So I think those conversations happening and being initiated by the folks like referring to JD or your onco team and ours, that's really cool.
Yeah, I agree with you. Like, I'm lucky that on my part of the week, the oncologist, the internist is really old school, but she's like all about ECT. So she referred to me like myasthenia gravis case. So she's really quick at talking to like a IMAG case, SNTP. And it's true that compared to the beginning of the week, because I'm on call like 24, I mean, every day basically for those cases, I have a flexible schedule. I don't get anything the beginning of the week, and I'm slammed on the second part of the week because I have those doctors that just kind of like, identify those causes, I mean, those cases. And even like some ER doctor or interns after my lectures, they just catch like those intoxication case from the ER board and just like cut them and, directly talk to me when, there is a potential to treat them. So having a team that's like, supporting the ECT services knowledgeable, it's making a huge difference, I feel, for like the caseload.
You bring up another interesting point that it hits home a little bit for me. If I understood you right, you are the single clinician that's running extracorporeal therapies in your practice. Is that right?
Yeah. Um, I'm lucky because I have a lot of nurses that want to, be part of the ECT service. Right now, I have like five, with four of them doing the academy. So, but it was kind of difficult because I had to kind of make them understand that I need to have a flexible schedule. Because if I have like an AKI coming on Saturday, it means that I'm coming on Sunday, on Monday, and maybe later during the week. And so I had to like work with them, and I had one of the ER doctor that's now will become a resident at she matched somewhere else. That kind of became like a critical care clinician working with me. So when I had to stay overnight for a case, I know she was there in the morning, and she could help manage my cases. So it's still a work in progress. It's not working great. I spent one day like 20 hours there and exhaust three of my nurses. But I was the most tired, but at the end, like it's just great because I'm able to like do really cool cases. But it's hard when you're the only one. I hope that we'll have someone else that will be interested to jump in. But yeah, I think without my nurses, I would not be able to do it.
Yeah, I think that's so true. And I think, as I look at so many of the names on the call here today as well, I think we're all really fortunate and dependent and blessed to have nursing teams that play such a significant role. I'm in a similar boat to you, Fabrice. I'm currently the single clinician here at Cornell that's got enough of the experience and such to run the program, but I've got a collection of nurses both in the academy and some that went to the boot camp, um, that I've now been able to leave the room more often than I used to be able to multitask and take care of other patients and other responsibilities. But I know Dr. Lobato's on the call here, and Carolyn up at Tufts. I mean, that's an amazing model of what she does for you guys. Would you mind sharing her role and kind of running the program up there?
Sorry, Jethro, I was multitasking. What was the beginning of the question? I was responding to some text messages.
Oh yeah, Fabrice and I were just going back and forth, as basically the single clinician in our practices running the program, how much we rely on a really solid and growing nursing care team to really step in and gain expertise and grow their expertise so they can run some of the treatments and, you know, be a partner while we work on expanding the clinician role. And I know Carolyn's like in charge of the whole shebang up there, it seems.
Yeah, I mean, I would say for anyone even thinking about starting a program, find the best nurse you can find who's interested and has a passion, and also has a passion for data collection for us to continue to do studies. And no, you cannot take Carolyn away from us. The hopefully not, but yeah, it gives us having a team like that with a nurse that knows the equipment as well or even better than the clinician is really very comforting, because if I get called away, or if Emmanuel or Nicole get called away because somebody's crashing in another area of the hospital, or we've got a meeting, I can feel comfortable that she handles the patient and the machine great. It really has expanded our abilities. It helps with instruction to the house officers, because our ECC and IM residents take part in training as well as cover on cases. So having that backup redundancy is wonderful. I think one of the important things is when everything is running so smoothly, as clinicians, we actually then have to almost force ourselves to go back and constantly look at the machine and what the latest upware and software is, or something like that, because she'll be 3 steps ahead of me, especially if I've been off for a month. I'll admit it readily. I think it has expanded our research capabilities. It has extended our ability to handle more than one patient at a time. So I guess that is probably all, that's probably it. I mean, it's the greatest thing in the world to have someone have that team approach.
Yeah, and I think what an amazing way to empower some of the like really important members of our teams that then give them the like Fabrice said, like several of his folks are in the academy. Like that's just such a cool level to help these folks and support them to achieve and give them the opportunity for that.
And also, if they're interested in teaching, it takes on such a teaching role. We actually run a first, second, and even third year student ECT team. And they come in, and Carolyn is fundamental in actually taking small groups of them in and getting them accustomed to setting up the machine and taking patients off, as well as the monitoring that's involved. And then they're an extra pair of hands for us as well, in that they each take a shift of being on call, and that helps them, that gives them course credit. And if there are no cases that are on that week, that come in that week, they still get the credit. So it really has encouraged student participation too. We used to get 1 or 2 semesters ago. We had something like close to 20 students that signed up for it. So it's really taking on a whole other aspect of training upcoming generations of people.
Right, and sparking that excitement at that stage of their career path, so that they can take over for the rest of us as we phase out eventually. Hopefully,
exactly.
I'll get there too. We've that's really interesting with the student part of it. So we've got emergency student workers and students that work in the ICU as well, and that's the population that I've kind of recruited from in a similar fashion. Layering in some course credit for it is another interesting twist to try and make sure they're recognized and given some something in return for their efforts. Yeah. Certainly from the after hours intoxications, that's where we've used them quite a bit. And right now, you know, a handful of them have gotten to the point where they're more than just kind of monitors and kind of record keepers and you know, great patient advocates, of course, as well. But it's you know, getting them to the place where you described, where they're taking patients, you know, off and being much more involved in the setup and things. That's another great way for us to try and get them to that point too. That's
Mhm. Yeah. And it's fine, once you have a group that comes through, there's often, you know, that student telegraph system, so to speak, that they you know, it's for the most part a not stressful rotation, and it's a 1 day a week, or half a day actually a week, when they have their selective time. And yeah, they spread the word that it's a lot of fun.
Yeah, and I mean, what I mean, I know I can speak for myself, but certainly the students that have a thirst and, you know, an interest, you know, what better way to learn than one-on-one for however many, 2 to 4 to 6 hours, or however long it is that they're sitting there,
Right.
right?
Yeah.
Getting that direct, you know, teaching and learning and that experience. That's awesome. That's some of the academic side. Fabrice brought in, you know, some of the private practice side. Is Jay still on the call? There's Jay. Jay, are you guys at MedVet? How have you guys dealt with the team approach to, you know, sharing the workload and getting the support that you need?
Yeah, I think our one of our residents, Natalia Stefanowska, is on this call too, as well as Drew. But yeah, I think our service is still in its infancy, but that is one of the rate limiting steps, is trying to figure out how do you manage a rigorous critical care caseload, burnout of your clinicians. And I think for all of us, a lot of it's that after hours intoxication cases never come between the hours of 9 a.m. and 7 p.m. So you know, how do you do that? So yeah, we're still in the, you know, I think the model with Carolyn Ty and some of that, we're still in the infancy of getting our nurses to that level, and we sort of feel that. So right now it's very clinician resident driven to do that, but we are actively onboarding and getting our nurses involved, and, you know, just had them sit in a couple of training sessions too to get them, because I do think it takes that village. So I think the model, you know, we don't have as much depth of students or interns as maybe a university-based setting, but I do think the support and the knowledge that we can pass on to the future generations and having our residents help with us right now is tremendous. But yeah, we're still very much in the getting our nurses to that place. Our other sort of med vets that are relatively successful in having similar models, like our Salt Lake City and NOLA, same thing. It was that amazing empowered nursing group that is also, you know, it's wonderful. They can participate in Dialysis Academy. They can have that learning available to them too. And it's not just the doctors, that I do think is probably going to keep this moving forward in the profession, because we need that 24/7 coverage.
Thanks. Have you guys had any interesting cases recently up at in Columbus?
This is Natalia. Drew, are you and Natalia on?
Yeah, we're here.
Okay. I was like, I'll let these two speak for that.
We had a severe Daramax intoxication Saturday night. The dog got into its housemate's Daramax, and it was somewhere between 75 and 90 mg per kg. And it ate it probably somewhere between 2 and 5 hours prior to presentation to actually one of our sister hospitals. So they called up and we chatted with them, and they sent the dog to us. And we decided to do hemoperfusion using the Purified Pump and Vet Rescue system. So we did a 2-hour, 2-device hemoperfusion session. The dog only vomited twice, very minimal clinical signs presenting to us. Did really well during the procedure. I think the biggest thing that was a little surprising for me is he was really hypercoagulable. His ACT going into the procedure before any heparin was only 69 seconds, and it took us 80 units per kilo to get him to be even slightly prolonged to just get on the machine. And then we were running him somewhere between like 60 and 80 units per kg per hour throughout the procedure. and it was like one of those situations where when I drew his initial sample to run our ABL, which is our venous blood gas machine, I got it into I ran the blood gas, and before I could put the blood into the hematocrit tube to check the PCV, it had already clotted. So I kind of knew we were setting ourselves up for that type of a situation even before we got upstairs. But he did really well on the machine, and overnight developed a little bit of regurgitation. The owners were slightly cost limited, so we weren't 100% sure if he was going to still get the GI side effects of the big NSAID intoxication. And unfortunately, we weren't allowed to keep him in hospital to find out. His kidney values prior to and the day following therapy were normal. And I actually just checked in with them yesterday, and they had just been to their referring that his kidney values were still normal, and he had taken a couple days to kind of get through the GI stuff, but was now eating chicken readily and getting back to his normal self. So overall, I think it was a pretty successful therapy, and it was one of our first after-hour endeavors. So Natalia and I came in with one of our nurses who is been very enthusiastic about learning how to do the different modalities that we have available, and has participated in the trainings that Jay was talking about. And so the three of us figured it out, and the dog did really well, and it was kind of a fun adventure.
That's awesome. How did you guys arrive at the 2-hour treatment target? Is that based on blood volumes or just an hourly?
So a little of both. We ended up processing about 20 blood volumes for the dog. The vet rescue devices become saturated at about 30 to 45-ish minutes with most NSAIDs. And so the recommendation is to use 2 devices in order to get below the therapeutic or the toxic range. And in reality, we don't really know what that window is. The goal is to obviously take out enough that they don't have severe clinical signs. And so on a few of the NSAIDs that we've done before, primarily ibuprofen, where we have a little bit more data, we've run the first device for about 45 minutes and then swapped to the second device and run that for an hour. And in this one, I just ran it a little bit longer. One, because it's not going to hurt to keep it on there. It just might not be effective. And 2, we just needed a minute to kind of get our ducks in a row and do the swap. So I did want to try to process. So we found 15 blood volumes would have been about 25 liters for this dog, and we did 20 ultimately. So I wanted to run us a little bit longer as well to try to get closer to what I thought would be 15 blood volumes. 20 blood volumes would have been 33 liters for this dog. And from a timing standpoint, from what I know about the device, I didn't think that there would be benefit on going longer to try to treat more blood volumes, because I thought that the cartridge would have been saturated.
You're using the small?
I used the
small column?
I used the 150 mil, the mid-size cytosorb column.
Okay.
So for that one is, I think, like rated for 20 to 40 kgs, and this dog was 20 kgs.
Okay. And how many milligrams were you trying to process? Did you have an estimate of that, though? Whether it would have saturated one column or not?
So we don't have, I don't think, that same data like that we do on the Amlogic charcoal.
No, I know we don't, but did you anticipate, like, how many milligrams did you have? Or grams do you think the animal ingested? Did you try to calculate that out?
Yeah, I need my calculator because I just don't remember it off the top of my head. 20. So it was somewhere between 1.5 and like 2 grams.
Oh, okay.
Of Daramax.
Okay.
Yeah,
So
a good group. I think we're in that, where I think even Jeff Barnes alluded to this last time we were at RRR. It's, in our sort of relatively novel standpoint of sort of taking this on, we're a little bit open to the advice of the device manufacturers, but I think we all recognize on this call that that's, based on those benchtop analyses. And I think as we're in the field and a lot of people are able, I don't think we didn't do drug levels on this particular one just based on the cost for us and private practice and the
Mhm.
owner. But, we recognize and the importance of sort of doing that because I do feel like a lot of this, when to switch it out, when it gets saturated, or all those, running it through an experimental model in the lab. And it does sound like as more people are expanding and doing this, those models may not, and again, the total amount and how it's distributed when these massive overdoses are happening. So I think for us, our protocol, now that we have the access to the charcoal cartridges, would be to use that for the ibuprofen, just knowing that, those are just massive, massive doses. But yeah, for these other off NSAIDs like Daramax, we were sort of like, okay, well, this is what the vet rescue group is recommending, and this is the time. But, I think if there's any other insights that this group is collecting that maybe we should run it for X amount of blood volumes or try to extend the time or, and how does that compare if we're using the polymer device versus the charcoal device is a chart we would love to have or, have available to us as we all add to that information.
We're working on it. Uh, yeah, I guess do you have access though to a -80, I guess, freezer? Because if you have some freezer access, I would recommend even though the clients might not be able to afford the assays, as we go for, if they'll give you permission for that extra little bit of blood, it's just samples. And, at some point, we may all have extra funding to be able to have more multi-center studies where those samples could be incorporated in a batch run of multiple centers. And because somebody's got some grant money for it, that it'll come and help. It will be, enormously helpful in the future.
Yeah, we don't have a -80 for long-term storage, but there was another research project I was working on across collaborations with another group, and at that institution they did, and again, it wasn't due for extracorporeal therapies, but yeah, if anyone on this call has a -80 and wants us to send you samples, we will happily bank them in short term, put them in our, -20 and then send them along. Because I agree, like it is a little bit of that private practice. We have a good caseload. We can initially collect those samples, how we get them somewhere where they can be banked or saved so that when dollars do become available, again, we'd love to have that information and be very open to participating in that as a cross collaboration.
Yeah, that would be great. We may have the space, Jay. We'll chat later.
Awesome. That's why I love RRR.
And I think from that perspective, I think we've brought it up on these calls a couple other times, but standardizing the timing of those samples being collected as well. And off the top of my head, I think the hemoperfusion guidelines, and I forget if anybody on the call is part of developing those. Was it 1, 3, 5, 7, and 10 blood volumes processed, and extras in between all that, but at least getting those standardized blood volumes treated and samples at those specific times so that we can compare apples to apples.
And I think not only the samples during the treatment, but I think it would be really interesting to gather some samples after treatment as well, just to evaluate if there's any rebound. Because it's something to get the levels at the end of the treatment, but what about 3 hours after that, 6 hours after that? And that might tell us more about the importance of the volume of distribution and maybe the need for sequential treatment or longer treatments.
Yeah, really great point there too, especially with some of the more lipophilic drugs that may go into tissues and then rear their ugly head and come back out the next day.
Yeah, we even have for some of them that are staying overnight or over 2 nights, we'll also try to get a sample sometimes at the 24 or 48 hour time point.
On average, for those of you guys that are doing that, like for most of the toxicity labs that'll run these levels, like 2 mils of serum, 4 mils of serum, like what is the average sample size that you guys, when you have had to send them off for analysis, you feel, obviously if it's a 5 or 6 kg dog, it's different, but most of these guys that we're doing, right, are 10, 20, 40 kg guys. So we probably have some space. I didn't know what you guys felt like the ideal sample size was for the typical analysis at these labs that are doing that.
Well, I think we usually just fill a standard small collecting tube, and whether it's, depending on the substance, whether we put it into a purple or a yellow top, we'll just put in 2 or 3 mils of blood, and whatever we spin off is what we're saving. So we're not going for a lot.
Gary,
I
how
feel
long
like-
would you have run this case for?
I'm sorry?
How long would you have done this case for on the 2 devices?
On the 2 devices? Yeah, I probably would have run it and try to process 20. Usually 20, depending on how long into the early morning hours. If it's midnight, we could maybe even go to 25, but if it's 4 in the morning, it becomes 20. And usually that will take us, depending on the size of the animal, you should be able to get that through usually within 2.5, 3 hours.
Okay. That's about where we were running by the time. Like we probably could have done, we could have easily time-wise, we finished around 1:30 in the morning. We probably could have gotten 25 blood volumes. I was just worried about the cartridge being saturated, or the device being saturated. Should I have just kept going anyway?
Yeah, probably, because once again, we don't know what it's going to take to get them in. Even the first cartridge may have actually still had some life in it as well.
Okay. So if you were doing that, then would you have processed, if you were going to say aim for 25, would you have done the first cartridge for 12.5, give or take, blood volume, and then the other one?
Yep.
So split it down the middle?
Yeah.
Okay.
Yeah, and all those, I mean, you guys hit on all those practical factors as well, time of night and resources available on the human resource side of it, and what you've got going on first thing in the morning. But yeah, that's
We were all back at, well, we pushed the day. We came back at 8 instead of 6.
Oh, that's you critical care folks. The medicine folks are still coming in at 8 or 9.
there you go. Did you guys, and this opens up maybe another can of worms as well. Did your sister hospital or you guys treat with the ILE and the wait or the build up to getting the catheter in and everything else?
We didn't. It was a situation where the dog came in right around 7 o'clock, 6:45, 7 o'clock, and they had called us very quickly, and the drive is about 45 minutes from them to us, and the dog was in our building by 9. So we were on the machine 10:30-ish.
Nice.
So our timing, I realized, it took us a minute to get everything going, and then once we were going, we were in the 2-hour treatment, but it was a relatively quick turnaround, I felt like, and I don't know, I feel like I've heard mixed opinions about whether or not we here's the can of worms, I suppose, treat with lipid ahead of hemoperfusion or TPE, and we didn't, obviously, in this case, and part of it was just we thought we could turn the case around pretty quickly. It had only maybe been exposed about 2 hours prior to presentation, so I wasn't as worried about reaching that 8-hour half-life. I thought we would be able to start treatment within that first half-life. So we didn't. What would you have done? What are your thoughts?
And mine personally are exactly as you kind of laid out your timeline. Like you were in that short window, and does it take more time to set up ILE while you're setting up and getting the patient in your hospital makes the most sense right off the bat. As opposed to, like I think on my ethylene glycol transfers, if they can get a dose of ethanol in them or 4-MP before they transport because of the, the rapid onset of the, metabolism of that particular toxin. That one I'm a little more concerned with. And these guys, I don't have the right answer myself, and that's why hopefully we'll get a few others, Dr. Lobato or Cedric, jumping in here as well to share some perspective.
Yeah, I think it depends on how long they're coming, where they're coming from. For us, if we're all in the building and we know they're coming, we'll have the machine set up and ready to go. If we're mobilizing the troops where some people are maybe close to an hour away to come in, then, and they're already in our ER, then yes, we'll say, just start the lipid. The other last week, or was it last week, we had one coming in and it was going to be a little fractious patient. So they would have had it to sedate and struggle to catheterize, to get the lipid in. We just were like, we're already here, just send it and we'll have everything ready to go. If they're 3 states away, then I'll say, yes, take the time and get the lipid going and either wait till it's finished or send them with the bag attached.
They have a little push on the road.
Yeah.
I mean, I don't know what this group is like. I think some of the reservations, and when we asked Parker, who's our representative for the vet rescue, whether or not there'll be interference from the lipid, like maybe in the charcoal that's been better ferreted out, but I guess in the vet rescue devices, is that lipid in the bloodstream going to impact how that device is working? And I don't know if we know that for sure. And I guess that's our ambivalence that, obviously there's a paper out showing with ibuprofen, maybe giving lipid, and that makes sense. Obviously there's some papers out showing that every once in a while lipid might have an adverse effect, so it's not benign. And in that, I think if we universally thought it wouldn't interfere with the devices, it seems like an easy, quick thing to get in them. I guess it's that other question of, do we think that'll then interfere with the device's ability to do its job for the NSAIDs? I don't know if there's a stance on that yet.
I'm not sure I've noticed that, but maybe, we'll actually have to, that's a good point, though. We probably need to go back and relook at some of the numbers on some that we did on the vet rescue versus a carbon column.
Cedric looked like you unmuted there a couple of times.
Yeah, I was gonna say it really depends on how far they're coming from. Like most of my cases are local, and I feel like asking for them to receive intralipids before we see them is actually more of a waste of time and just delays the time they're on the machine. I'd rather have the case sent right away and put them on the machine right away. But again, if there's like 2-3 hour drive, it may be worth to get a dose before being driven down. As far as intralipids, I think also not only for hemoperfusion, but we have to take that into account for TPE, especially for those doing filtration TPE. I feel like it might clog the filter pretty bad compared to those who have the option to do centrifugal TPE, where it's not that much of an issue.
Erica, I'm not sure if you're actually back there listening or multitasking like we are. What do you guys, how do you approach these at Penn?
I'm listening. It's a good question. We're actually working with cytosorbents, doing a study on the vet rescue. And so we've had a protocol in place that we do 9 blood volumes on the first device, and then we change it out and do 9 blood volumes on the second device. I agree that there's saturation occurring. I think at what blood volume is a little bit trickier to say. I think it's a little bit dependent on the NSAID, for example, and we're still teasing that out. But yeah, I guess we do 2 devices as well for the same concern with saturation. I think the one thing I would suggest being cautious about is if you change the device too early, you could maybe reduce the platelets. I don't know if you guys have seen thrombocytopenia, but if you don't allow maybe time for the platelets to kind of come off the device, if there's had any like accumulation of platelets there, that would be one concern with a really early device change. So I would just mention that we've had a few dogs have huge drops in platelets, like huge, like 50% with each device, which is scary. And then we've had others less so. I think that making sure you get them into the target ACT is really important. And I guess like your heparin dose that you had to give like 80 units per kilo per, that's not, in my experience, that hasn't been uncommon for these young, like healthy dogs. They tend to need more heparin than our like AKI dogs, I would say. I don't know if that helped at all, but
I mean,
I
that
do
definitely
think
makes me feel better. I was like, I feel like I just keep giving you more heparin. And
No, you'll get used to seeing it like maxed out on your ACT, and then they're still clotting. You're like, why are you doing this? You're a cat. But with what Erica just mentioned with some of the profound platelets, we just did a cat last week, and we're like, well, okay, we finished on early in the morning hours. We figured, well, we can take it out on Thursday. This was Wednesday. We'll take it out on Thursday and get the cat out the door. We'll just check the platelets. And because they always drop down, but I'm comfortable pulling the catheter at 40 and not having problems. It was 7,000. And they're like, we're thinking, well, okay, they come down. Usually they're back up to something we feel comfortable by the day after that then. So the next day, 7,000. This cat finally rebounded, and we were able to get him out the door on Sunday. Didn't have any complications otherwise. I mean, he wasn't clinically having any issues. He, I think, had one little bout of diarrhea, and we're like, okay, the hematochezia will be coming shortly, but no. Ate fine, but those platelets I'm like, we'll just leave that catheter in just a day or two longer.
and was that with the vet
Right.
rescue?
Yeah.
Yikes, scary
Yeah.
stuff.
I'd say it's
The
not.
lesson to
not
learn
my
is just don't look at those darn platelet counts.
The surgeon approach. I think that's really good advice though, because I don't know that I had thought through that part of it. And admittedly, even on this dog that we treated this weekend, I checked a chemistry the next day for his renal values, and he had adequate platelets ahead of time. And I did get an out the door ACT, and that was normal. So I felt good about it, but I don't know what his platelet count was leaving the hospital.
He clotted very quickly.
But he clotted very quickly, apparently. So
After we removed it.
Yeah.
Dr. Lobato, was that a cat NSAID ingestion that you guys treated?
That was a cat. Well, it was a double whammy. It was a cat NSAID followed by gabapentin. He got both in one mouthful, just about. It was his household dog's medication.
And here I thought cats were supposed to be smarter than that.
Yeah, not this one. He was a known I'll eat anything kind of guy, and had a few other episodes of at least non-toxic based ingestions, but
Erica, with the work that you're doing with the vet rescue device, are you seeing that prolonged thrombocytopenia as well, or are they usually rebounding more quickly?
That's a good question. I think the ones that haven't dropped, obviously we haven't been worried about. The ones that took a little bit longer, I would say, were ones that presented to us maybe late post ingestion and developed the clinical signs like really severe GI upset. So it's hard to know whether the platelet loss was just the vet rescue or whether there was some contribution from GI bleeding. That particular dog I can think of took a little bit longer to rebound, but I guess I wouldn't say we're checking unless they drop really, really low. I'm just saying, like, if they start at 250,000, like worst case scenario, we're seeing like a 50% drop with each device. So you just kind of have to think about where you'll be at the end of it and whether you would want to do a second device, if that makes sense. But then I had a couple cases where we didn't see a lot of platelet loss. And so we're still trying to tease that out, like what the difference is with that.
And I guess are we, and maybe I should have more insight into this than I do, but are we, I mean, is it that they're being sequestered in the devices or destroyed? Do we have some sense of that? Because the rebound seems to happen, at least in some of the literature that I've read, after they're off the device. So I think if they were trapped in the device, they're rebounding on their own. Do we have some sense of that physiology?
That's what we're going to try to look at that coming up. But at first I was thinking more kind of I think it might end up being a combination between activation and trapping.
Cool.
With the kind of like uncertainty about the efficiency of the, hemoperfusion, like how comfortable are you to treat those intoxication with those cartridge versus like doing a TPE treatment? Because sometimes I'm like, I don't know, I'm not always convinced with the data that I saw that, I'm not doing the best job with the TPE, and I feel a bit more confident that I remove most of it. But I don't know if, maybe I'm missing some data or you guys have like a better
So
insight.
I've been looking at that a little bit lately because I had the same reservation with the hemoperfusion. I didn't feel super comfortable on how to prescribe the treatment to make sure we extract the most of the molecule, and I felt more comfortable with my TPEs. But we've been running pre and post and SAID's values on probably a dozen TPE dogs and a dozen hemoperfusion dogs so far. And the results tend to show that when we treat with like 20 blood volumes or so, the reduction ratio in the serum levels is actually greater with the hemoperfusion than with what we get with TPE. And I'm pretty aggressive with TPE. I go up to 2 plasma volumes most of the time. And even with that, I'm more like in the 60% reduction, about 60%. When we get 75 or more with hemoperfusion and 20 blood volumes, that's my feeling. And we'll need to gather that with more data from several other centers. But I've been transitioning from being more confident with TPE, and I would be on the side of like maybe hemoperfusion will be a best choice.
And Cedric, is that with the carbon device?
Yes, it's with the carbon.
Yeah, I think that's an interesting question, Erica, because I think we some of us are using both adsorbent devices, and some maybe in one camp or the other. It may be from a costs of supplies on the shelf perspective, hard to carry both. MedVet, are you guys carrying both?
Yeah, I mean, we because I feel like for the ibuprofens that are those massive doses, we just felt like we needed the charcoal. Like I'm just not convinced that I mean, it might, and maybe the data will come out with the vet rescue, but I think when it's those massive numbers, like just knowing a little bit more that the carbon, again, depending on which size you use, has a saturation value that'll hold those just massive doses. So we decided to carry both. So we have the kind of whatever mid-size large carbon from Amylogic, and then we have all multiple sizes of the vet rescue. And obviously the carbon can do some of the things that the vet rescue can't. The vet rescue does have a little bit of a more clearly defined high efficiency versus low efficiency of certain drugs. So we have both so that we can offer both services. And I think even in the TPE versus hemoperfusion, for us, it's, we've been able to navigate some cost reduction for our plasma, but the TPE outprices us on the hemoperfusion every single time. So if they're even relatively close, or maybe let's say, the data shows that hemoperfusion is maybe 10% less efficient than TPE, the cost difference for these clients just means the difference between doing it or not doing it at all.
Yeah, that was the thought, Jay, that went through my head. If I've got unlimited funds, then yeah, the decision is maybe a little more complicated. But if it's hemoperfusion where TPE could be a better clearance modality, but they can't afford it, then I'm going to go down the same path you guys did. That makes good sense.
Mm.
Awesome. Well, these are really fun conversations to have. I'm so glad that you guys all shared different a couple of different cases here today. The hyperviscosity syndrome at Friendship, and the NSAID toxicity out in Columbus, and then that spurred a lot of good discussion amongst the Penn folks. And looks like Cedric, oh, there he is, still on the screen, in San Diego, and up at Tufts. This is really a great group leading the way and learning and sharing. And I think that's where we've got to get to, is sharing all this information. And if Tufts doesn't work out with their -80 for you guys in Columbus to send to, I don't have a -80 fridge of my own, but I'm starting to carve out space in other people's -80s. So I'd be happy to hold on to some samples too, if that makes some sense, because I think that's the only way we're going to answer some of these questions, is actually getting, and again, multi-institutional, multi-sites, data and sample collection and analysis. It's the way to go. So sweet. Well,
I have a quick question about the -80, because I was looking for one and someone told me that because we have like Therology that has like the liquid nitrogen. I know that can go like lower than -80, but do you think it's like a viable option to keep samples? Does anyone have that information?
I don't know.
Okay.
yeah, I'm sorry, I don't either.
Okay. Thanks.
No. Well, terrific. Well, thanks. We're at the end of the hour here. Appreciate you guys being so engaged and making it gentle for me, kind of filling in for Dr. Cowgill this week. Hopefully he's back in a couple of weeks' time to take back the reins. If anybody wants, traditionally, he offers up the last word to anybody else on the call. Does anybody want the last word? Happy Friday then. Keep doing what you're doing. This is awesome, and I'm excited for all the great work we're doing.
Take care, everyone.
Bye now.
Thank you.